All right. This meeting's called to order. Welcome. This is our first July board meeting of the season. Our meetings will continue to be hybrid. HCA staff are going to continue to be on site when possible, and board members and other attendees have the option of attending on site or via Zoom. For members of the public attending via Zoom, our opening slide has information on how attendees can turn on closed captioning subtitles. Also, public meeting attendees will be only able to activate their audio and video during public comment periods, and here at the agency, we'll be able to control that function. For board members attending in person, make sure you turn on your microphone when you're speaking so your comments are captured on our audio recording. Let's go ahead and do introductions. Sharon, I believe who's attending virtually.
Present.
There we go. Elliot.
Here.
Tom.
Present.
Michaela.
Here.
Kurt.
Here.
Harry.
Here.
John. And it clearly says that. It said May. So there we go. I got my break there. John will not be with us today. And Michael Tunick from the AG's office.
Present. Thank you.
And I'm Lou McDermott. I'm the COO here at the Healthcare Authority, filling in for Marianne today. While board members attending both in person and virtually, it'd be helpful for board members to hold their questions until the end of the presentations or when the presenter pauses and asks for questions. If you're in virtual land, raise your Zoom hand. We'll keep an eye out for you. And if you're here, raise your real hand and we'll call on you. We have a few resolutions scheduled for action for today's meeting. The public will be able to provide comments specific to each resolution before the board votes. The public is also going to have the ability to provide general comments at the end of the meeting as we normally do. As a reminder, if the public has questions during a presentation, there is an email address on the presentation that they can send their question to, and we'll try and get to that on the fly or after the meeting. Dave, what do we have going on today?
Good morning, Chair McDermott, members of the board. Today is the day that we have you vote on Medicare premiums, the Medicare portfolio. So after today, hopefully there will be Medicare plans. Remember, until the board takes action, no plans exist for 2026. There's a completely blank slate. Majority vote needed to authorize a plan going forward. So after today, hopefully we will have a suite of Medicare portfolio plan offerings to our retiree community, at least the Medicare part of the population. After that, we'll proceed on with a presentation about some modifications in the non-Medicare portfolio benefit design that are wrapped into the rates, which Tanya will then present the premiums that are proposed for the non-Medicare population, both employees and non-Medicare retirees, and we'll ask you to take action on those next week. We will then round out the meeting with a preview of the 2026 board meeting schedule, and then we will be done for the day. I did forget to say at the beginning of the meeting, though, after you vote on the minutes, we will have a brief executive session to round out some of the final aspects of the procurement process and rate development process with some of the proprietary information to share with you. Beyond that, a couple of other pieces. You may be wondering, I thought that there were hearing aid resolutions that were supposed to come back for action today. We've been working on some follow-up questions and some additional answers into the materials and just needed that extra week buffer. There was no rush to have those done in advance of today. So those are going to be brought for your action and consideration at next week's board meeting. A couple of other housekeeping pieces. You may notice at this meeting we have some visual aids in your before you. This is a new feature because I noticed between the boards, and I'm not going to single out anybody, but I noticed several people needing to look very closely and bring their papers closer. So we decided just to have magnifiers in person that can help. As we learned yesterday, if you feel it, there's a scratchy side and there's a smooth side. It works better if the scratchy side's up. So the subboard had a lot of fun with that yesterday. So feel free to use those if needed. We know that finances numbers are sometimes small. They're small for everyone, including myself. So just another way to help you have access to the materials. Then if you need the restrooms, go down the hall. If you see elevators, look to your left. If we have an emergency, we walk purposefully across the street into the visitor parking lot.
You all don't seem very enthused. Seth was over the moon. We were playing for 10 minutes.
Yep.
Dave, continue.
That's what we're doing today. Back to you, Chair McDermott.
Any questions for Dave? All right. Why don't we go ahead and approve the June 26 meeting minutes? They're behind tab number 3. Are there any comments from the board?
Yes.
What is your comment?
Well, this is rather picky. These are the minutes.
These are the minutes. What you got?
Page 3,
All right.
I found a typo.
Okay. Tab number 3.
Line 3. And it's under Lauren Topfer, I believe is how you pronounce
For
Tepfer. I'm sorry. And it's children up to, there's a typo.
and the third line, I see it. UPT space O is not how you break up the words up and to.
So we'll just, you know what, we're going to update it and we'll bring it to the next meeting and we'll take another shot at it.
Yeah.
All right. Thank you, Elliot.
Any other comments for revisions, updates?
Anybody see anything else? All righty.
We will bring that next meeting then.
All right. Off to executive session. We're now going to transition to executive session. It's going to happen here in Sioux Crystal for board members and include HCA employees who are necessary for executive session. At this time, members of the public joining us in person at HCA today and employees who are not part of executive session will be asked to wait in the main lobby for the duration of executive session. You'll be called back to join us in Sioux Crystal for the remainder of the meeting. Pursuant to RCW 42.30.110 subsection 1L, the board will now meet in executive session to consider
Yeah, it's not-
proprietary or confidential non-published information related to the development, acquisition, or implementation of state purchased healthcare services as provided in RCW 4105.026. The executive session will conclude no later.
Like yesterday.
The executive session will conclude at 9:50. So there was an issue with, do we come back early? Is that possible? We're coming back at 9:50. Board members, let's take a quick break while we transition into our executive session. And if you're virtual, please use the separate link given to you via email for the executive session, and we will pull you into that meeting. The link was sent Tuesday at 1:05 p.m. We will return to our public meeting, continue with our agenda after the session ends. All right, let's transition. All right, thank you, everyone. We are back from executive session. And our first presentation is Molly Christie, fiscal analyst in the Financial Services and Healthcare Purchasing Administration, is going to be bringing back the plan year 2026 Medicare premium resolutions for voting today. After Molly reviews the resolution with us, we're going to ask for a motion to adopt a second. Then we're going to have public comment period. Then we're going to have discussion from the board until we're ready to vote. The materials behind tab number 4. Molly, welcome.
Thank you, Chair McDermott and members of the board. For the record, I'm Molly Christie. I work on our finance team, and I am presenting the 2026 PEB Medicare premiums for board vote today. As a reminder, these are the 2026 Medicare retiree premiums that I presented at the last board meeting and that the board will be taking action on. These premiums also include the minor benefit changes that Laura discussed on June 26th. So if you need to refer to those board materials, please do so. The next slides introduce the PEB Medicare retiree premium resolutions with a few modifications from the proposed resolutions you saw last time. I will walk through all of the changes. As a reminder, the board is asked to vote per carrier, which adopts all of the PEB Medicare plans offered by that carrier, as well as the premiums and the benefit designs underlying those premiums. In our last meeting, one of the board members wisely suggested a revision to the Medicare explicit subsidy resolution that would prevent the board from having to take action on that resolution every year. This slide shows the proposed resolution as presented on June 26th, which would set the Medicare explicit subsidy at the cap that was set and funded by the legislature for 2026, which is $183, or 50% of the premium, whichever is less. The revised resolution on the next slide for action by the board today permits HCA to apply up to the maximum monthly subsidy amount for each plan as established by the legislature and in compliance with RCW 4105.085. And you can take a moment to read through the language. You'll see this again when Chair McDermott asks you to take action. All right, on the next slide, RCW 4105-085 gives the legislature authority to establish the Medicare explicit subsidy, and the amount of the subsidy is included in the budget bill. However, this statute limits the subsidy that may be authorized by the PEB board to no more than 50% of the premium for each plan. So we wanted to provide this as context. There are kind of two sources for where this, where the subsidy cap or 50% comes from. So I will hand it over to Chair McDermott to introduce the new Medicare explicit subsidy resolution for board action.
Alrighty. This is Resolution 25-07, Medicare Explicit Subsidy. Resolved that the PEB Board authorizes the Healthcare Authority each calendar year to apply the monthly Medicare Explicit Subsidy for each plan up to the maximum amount established by the legislature and in compliance with RCW 4105-085. Is there a motion to adopt?
So moved.
Is there a second?
So move.
Are there any comments from the public? I'm looking at the public over there. And anything? Nope. Seeing none. Any additional comments from the board?
I have one, and
Fire
I
away.
am only saying this if it will not require us to slow down and revote. So I will retract if it, but
It's
just,
fascinating. I know I'm dying to hear.
well, I like the resolution, and as someone who, I like to also see like what the actual subsidy is, to see like the 183. Is there a way to just link somewhere so that people can easily find it? Because I think the one issue with it being more generic, of it saying, you know, like what the apply the monthly Medicare explicit subsidy for each plan, is you don't necessarily get to see the detail of it. So
I
just
see.
wanting to see, like, if someone is interested, being able to find that information so they're not lost and just being like, what does that mean?
Is the subsidy buried in the budget bill?
It's buried in the budget bill. What I think I should reveal what I intended to happen here is like we have been bringing information on the high deductible health plans deductible needing to be raised. And I said we keep the board informed every year when the agency is exercising the authority that the board gave us to be able to chase the minimum deductible there, that we would be in all of our materials each year, putting in our materials and bringing to the board, this is the subsidy that's being set. And Molly or anybody, you know, the finance would, and Molly would be sharing that and showing the math of it every year anyway. So we will be incorporating it in all the materials, and it's a prominent number that needs to be shared with everyone. And so it will be pervasive in all our materials. We just wouldn't have to have you vote every year.
Does that meet your needs?
Yes.
Excellent. Others? Tom, I see your little light on.
Oh,
And now I see your light off. Elliot, your light's on. All right. Now, this is going to be a roll call vote. Starting with Sharon.
Agree to adopt.
Elliot.
Aye.
And Kyla.
Yes.
Tom.
affirmative.
Kurt.
Yes.
Harry.
Yes.
And Lou, yes. Resolution 25-07 passes. Thank you.
Okay. And I think in the future it would be me bringing it back unless Dave knows something. I don't know.
I didn't want to commit you to working for the agency indefinitely. That's all. I just had that awkward
Molly
pause
will
there.
be back year after year after year with no opportunity
Yeah,
to
right.
leave or advance.
Yeah, thank you. Yeah, I would realize the awkwardness stuff, but I was like, I don't want to commit Molly to being at the agency for her entire life.
Appreciate that. Before I transition again to Chair McDermott to lead us through the premium resolutions, I want to note that all premium resolutions introduced on June 26th have been revised for clarity. Specifically, they include the applicable calendar year of the premiums that the board is taking action on. So it's a very minor change that we wanted to call out. That is the only revision to the resolution language.
All right. Resolution PEB 2025-08. Kaiser Foundation Health Plan of Northwest Medicare Premium. Resolved that the PEB Board authorizes the Kaiser Foundation Health Plan of Northwest Medicare 2026 Premium Plan, or Plan Premium, other way around. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the public? Seeing none, any comments from the board? All right, our roll call vote, starting with Sharon.
Agree to adopt with reservations.
Elliot,
No.
Michaela,
I'm gonna say yes on this one.
Tom,
Yes.
Kurt,
No.
Harry,
Yes.
and Lou, yes. Resolution 2025-08 does pass. Molly?
This is for the Kaiser Foundation Health Plan of Washington Medicare premium for 2026.
All right, we're going to be voting resolution PEB 2025-09, Kaiser Foundation Health Plan of Washington Medicare Premium. Resolved that the PEB Board authorizes the Kaiser Foundation Health Plan of Washington's Medicare 2026 plan premium. Is there a motion to adopt?
So move.
Is there a second?
Second.
Any comments from the public? Seeing none. Any additional comments from the board? Roll call vote, starting with Sharon.
No, with strong reservations.
Elliot,
Yes.
Michaela,
Yes.
Tom,
Yes.
Kurt,
Yes.
Harry,
Yes.
and Lou, yes. Resolution 2025-09 passes.
The next resolution authorizes the United Healthcare 2026 Medicare premiums.
Resolution PEB 2025-10, United Healthcare Medicare premiums. Resolved that the PEB Board authorizes the United Healthcare Medicare 2026 plan premiums. Is there a motion to adopt?
So move.
Is there a second?
Second.
Any comments from the public? Seeing none. Any comments from the board? Vote starting with Sharon.
Agree to adopt.
Elliot,
Yes.
Michaela,
Yes.
Tom,
Affirmative.
Kurt,
Yes.
Harry,
Yes.
and Lou, yes. Resolution 2025-10 passes.
The next resolution adopts the Premera Medicare supplement premiums for 2026.
All right. Resolution PEB 2025-11. Resolved that the PEB Board authorizes the Premera Medicare Supplement 2026 plan premiums. Is there a motion to adopt?
Yes.
Is there a second?
Second.
Are there any comments from the public? Seeing none. Any comments from the board? The vote will start with Sharon.
Agree to adopt.
Elliot,
Yes.
Michaela,
Yes.
Tom,
Yes.
Kurt,
Yes.
Harry,
Yes.
and Lou, yes. Resolution 2025-11 passes.
The final resolution adopts the UMP Classic Medicare with Part D 2026 premium.
Resolution PEB 2025-12, resolved that the PEB Board authorizes the 2026 Uniform Medical Plan Classic Medicare with Part D 2026 plan premium. Consistent with open enrollment operational timelines, HCA has the authority to lower the 2026 premium if the Centers for Medicare and Medicaid Services continue the Medicare Part D premium stabilization demonstration. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the public? No? Any comments from the board? Voting starting with Sharon.
Yes, agree to
Elliot,
adopt.
Yes.
Michaela,
Yes.
Tom,
Yes.
Kurt,
Yes.
Harry,
Yes.
and Lou, yes. Resolution 2025-12 passes. Thank you all. Thank you,
Thank you.
Molly.
Thank you, Molly.
We'll see you maybe.
I'll just say, I know for members of the public who might be listening, that seems very fast. It's the culmination of a lot of work. The formalities of the vote process can be very quick, but it represents an extensive amount of work by the finance team, by the agency, by the board and executive session and understanding what's happening with various rates. And so just appreciate your support. And we now have a suite of Medicare portfolio plans. 10 minutes ago, we had no plans. Now we have a suite of plans.
I like to think of it as the ceremonial cutting of the
Yes.
ribbon.
Mhm.
We built the house. Now we gotta.
And now we transition our work to non-Medicare. Chair McDermott?
There we go. Beth Heston, our procurement manager in the herb division, is going to review the plan year 2026 proposed benefit changes for the plans and PEB programs non-Medicare portfolio. Materials behind tab number 5. Beth, welcome.
I pressed it once. Good morning, Chair McDermott, members of the board. I'm Beth Heston, and I am the procurement manager for PEB. And I want to talk to you today about the overview of what we're going to look at. First thing we're going to look at is IRS minimum deductible updates to our consumer-directed health plans, the CDHPs. Then we're going to move through the Kaiser Foundation Health Plan Northwest proposed benefit changes and move on to the Kaiser Foundation of Washington proposed benefit changes. Next slide. So if you recall from last meeting, Ryan Ramsdale spoke to you about the change made by the IRS to the annual minimum deductible. The floor, as it is, of the deductible has raised by $50. You made a decision in the past to allow the UMP plan to continue to chase that floor. That also affects, your vote doesn't necessarily affect, but the IRS changes affect our fully insured plans. And so for next year, Kaiser Northwest and Kaiser Washington CDHPs will rise. The minimum floor will go to $1,700 for individuals, $3,400 for family. Any questions? Next slide. So now we're going to talk about Kaiser Foundation Health Plan of the Northwest. This is, again, the smaller of the two regions that we deal with. They are just in Clark and Cowlitz County in the bottom corner of Washington. Next slide. Thank you. There's going to be a change to hearing aids. The OIC had agency request legislation to change essential health benefits and coverage of hearing instruments was voted into that essential health benefit so that every plan has to cover. And so in response to that, Kaiser Foundation is going to begin covering hearing aids a little bit differently than they have in the past. And that is through their own established network of providers. This network is comprised of Kaiser Northwest owned facilities. Members must see a Kaiser Northwest provider for hearing aid hardware. Yes, ma'am.
Does that include cochlear implants or is that a separate category?
I think cochlear implants is a separate category because they are medically necessary and they're implanted. So these are just in the ear. So under these HMO plans, members must receive their hearing aid from a Kaiser Northwest provider or there's no coverage. So if they want coverage, they have to go to a Kaiser provider. If they receive their hearing aid from that Kaiser provider, there is no amount out of pocket. That does not, of course, apply to the CDHP because they must meet their deductible before things are completely covered. So.
So just for my information, so right now, if I'm a Kaiser Northwest subscriber, am I allowed to go to other places for hearing aids? And this would be a change?
No, the difference is that there was a benefit limit and the essential health benefit does not allow a limit of dollar coverage. So nothing has changed about the way they're covered. Instead, it's the amount that's covered. So, so we're moving on to Kaiser Foundation Health Plan of Washington. And surprise, surprise, next slide. These are the same rules for Kaiser Washington. Kaiser Washington, of course, covers many counties in Washington state. Again, Kaiser-owned facilities, you have to see them if you're a member. It has to be an in-network provider. You have to receive that hearing aid or there's no coverage. And if you get it from the in-network provider, there's no out-of-pocket except for CDHP. Yes, ma'am.
One other, I thought I might be conflating the two, but I thought I remember some sort of caveat that even if they go in network, a statement of necessity could still be required by Kaiser to say that that particular hearing aid is needed.
Yes, if they have a specific need, they would have to, and that's the way it is now as
Okay.
well. You have to establish medical necessity.
But like, I thought I remember something around like, they can still say like, I go to an in-network provider, there are 3 options. My medical provider says you need the most expensive option. That Kaiser still has that pathway to say, prove it, that you really need that more expensive option, even if it's in network.
If it's a Kaiser provider, they're going to give them what they need if it's medically necessary.
Yeah, Michaela, I think what you're describing, we wanted to put the information about Kaiser here because we've had the conversations about UMP. And where you're thinking is a little bit about kind of the interaction in a PPO. And I think there was a conversation last meeting where it's like, there's drawer A and then there's drawer B. And to get to drawer B, you might have to prove more medical necessity. That kind of concept doesn't really exist at Kaiser. They're in their audiology center. What is medically necessary for you? If yours is a retail value of a $2,000 hearing aid, covered. If your medical necessity, Tom, is a $4,000 hearing aid, retail value, covered. You're thinking a little bit more of the PPO framework. Okay, just making sure that I got that right. Turn around to my Kaiser folks and then yes, it's like.
All right, next slide. And that's it.
Any additional questions for Beth?
Question.
Yes, sir.
When it says in network, I haven't been in Kaiser for a while, but is it, do they have non-Kaiser providers or is it all?
No, it has to be in network. You can't go to Costco.
Okay.
That's basically what it boils down to. It's not a PPO. You have to stay with the doctors that are available or the providers that are available to you within the network.
I think the question you're asking is outside of their Kaiser facility. You mean, do they contract with other providers in the
Yes,
community?
They do.
They do
That
have
is not Kaiser, but they're still.
Well, because they have a contract, they're considered in network. So.
Yeah.
So there are audiology centers, which you might think of as a classic brick and mortar you go to get your test, and then there's the hearing instruments around that are kind of Kaiser owned capital, if you will. And then there are also additional providers that aren't in those brick and mortar audiology centers, but the contract means they're in network, whether they're in that brick and mortar audiology or a separate individual contract.
Okay, thank you.
Other questions for Beth? Beth, thank you so much. We're going to go ahead and take a 10-minute break, and then our next presentation is going to be non-Medicare premiums by Tanya Duell. So we've got 10:14. Let's go 10:25. All right. Sorry about that, folks. We're running a tick late on that. Let's see what we got here. Next up, Tanya Duell, ERB Finance Manager in the Financial Services and Healthcare Purchasing Administration, is going to provide some information regarding the plan year 2026 non-Medicare premiums. Tanya is also going to be introducing resolutions related to the 2026 non-Medicare premiums today, but no action is scheduled for this meeting. We anticipate voting on these at our next meeting on July 17th. Materials behind tab number 6. Tanya, you're on.
All right, thanks, Chair and members of the board. On next slide, we're just going to do a quick reminder of our timeline here. like Dave mentioned during the Medicare resolutions, this has been a long journey. So what we're presenting to you has been many months of negotiations and conversations. This process actually starts early in February with our release of our RFR, which is a request for renewal. Each of our carriers have to respond to. Then in May, actually May 1st, we get our first round of rates turned back into HCA, which kicks off the negotiation process with our fully insured carriers. As a reminder, we do not negotiate rates for UMP with Regents. HCA with our contracted actuary actually determines the rates for UMP. We are not negotiating those. And then in June, we work to have all rates finalized for presenting to the board in July. So we're here today to publicly present our final round of rates that are proposed to the board, and then we'll ask you to take action and authorize those premiums at the next board meeting. Before we get into rates, just do a little reminder of how the employer portion of the rate is determined for our employees. So we do what is called an EMC, which is the employer medical contribution. It's actually something that's part of the collective bargaining agreement, but applies to all active employees. So this is something that's up for consideration during each bargaining cycle. Currently, the collective bargaining agreement states that the EMC will be an amount equal to 85% of the monthly premium for the self-insured Uniform Medical Plan Classic for each benefits eligible employee. It's a lot of words, but it's fairly simple when we break it down here. So the illustrative example for the EMC calculation is we take the UMP Classic bid rate. In this example, it's $800. We then multiply that $800 by the 85%, which means the EMC, the employer's medical contribution towards that rate, will be $680. That's subtracted from the $800, meaning the employee on this plan would pay $120, the remainder. As we walk this through multiple plans, you can see that that middle line, 680, is the same regardless of the price of the plan. So on this example, we have plan rates ranging from Plan A at $700 up to Plan C at $800. So regardless of the price of the plan, the state is contributing that same $680, meaning the employee picks up the difference. So if an employee in this situation chooses to enroll in Plan A, which is a lesser expensive plan, they would pay $20. Whereas if they enrolled in the more expensive plan on this example, they would pay the $120. We then take those single subscriber employee premiums one step further on the next slide, and we roll them through the various employee premium tiers. So the single subscriber is just that tier 1, which is the 1.0 rate. When this employer subscriber adds their spouse or state registered domestic partner, we multiply it by 2. An adult is worth 1 in this program, so 2 adults is 2. For an employee, the subscriber and child or children tier, we multiply it by 1.75. So regardless of the number of children on the account, we add that additional 0.75 on there. And then the final tier is the subscriber, their spouse or state registered domestic partner, and their child or children. We multiply by 2.75. This is the same for the bid rate, the employer medical contribution, and the employee premiums. So the next slide is the first look at the proposed employer and employee contributions. How this slide is laid out is by carrier on the left. So we have Kaiser Northwest at the top with their 2 plan offerings, Kaiser Washington in the middle, and at the bottom we have the Uniform Medical Plan offerings. We'll do a little pause here to note that for UMP, you no longer see the plus plan here. As we're all aware, the plus plan is closing at the end of the current plan year, so we are not bringing forward a plus plan rate in this deck to you. When we get to the resolutions, because there is no rate here for the plus plan, it will no longer exist when the board next week authorizes the UMP resolutions. All right, so when we look down the left, we have carrier. The next set of numbers is the bid rate. The bid rate is the total rate, the rate that is bid by our fully insured carriers or developed for the Uniform Medical Plan. You'll notice in the middle column, the employer contribution is the same. For 2026, it's coming in at $820. So if you were to look at the UMP Classic bid rate of $965, 85% of that is the $820. And then you do the math all the way across for all of the plans. Bid rate minus the 820 equals the employee contribution on the far right. We're going to jump to the next slide because I think this is where the numbers get a little more telling. And this is comparing year over year. So the layout's the same with the carriers in the same order and the plans in the same order. However, this slide is comparing the 2025 employee premium, so what employees are experiencing today for that plan, versus the proposed 2026 employee premiums. And then a change year over year. So the dollar amount and the percentage. So this is the change for a single subscriber from what they're paying today versus what they would pay in 2026 for that plan. And on the far right, we have enrollment broken down by plan. So Kaiser Northwest, you can see their enrollment at the top, Kaiser Washington there in the middle, and then on the bottom, you'll see the UMP enrollment numbers. All right. I want to talk a bit about some of the relativity and the leveraging that the EMC has on employee premiums. You can see that the UMP Classic is increasing by 8%. That means that any bid rates for other plans that came in higher than 8%, the employee picks up that additional increase above and beyond that 8% that the state is picking up. In a case where the bid rate comes down, I think we only have one example of a decrease and one example of it remaining flat is UMP Select. The bid rate actually came in a little less than UMP Classic. So the employee in this situation will experience a decrease in employee premium of $1. So keep that in mind as we talk through some of these increases. But ultimately, what we have presented to you today is the final round of rates. These reflect our carrier's final round of rate offerings for us. Like I mentioned, we negotiate over many, many months. We do bring the board along the journey in executive sessions where we can discuss some of those proprietary and confidential rates. It's been a bit of a journey. I think what we see here today are some rates that are a little bit larger than we would like to see from historical averages. I mean, across the industry, we are seeing some larger than normal inflationary pressures on healthcare. So we're seeing that through a lot of our plans. Specifically, though, I do want to, mention we did start in a very different place. I want to acknowledge our team and the amount of work we did this year to get to the place where we are today. The rates did, kind of start in a different place, and throughout the months and negotiations, we are able to bring those to where we are today. What's being presented to you. I'm gonna move to the next slide just for a second here.
Tanya, one thing to go back to the prior slide. This time of year is when lots of different parts of the market are describing what their rates are going to be for 2026. And so there's often a lot of comparisons that folks try to make across different parts of the commercial market. So one place people will look is I don't think the insurance, there's periodically, sometime in the summer, there's usually a news release by the insurance commissioner's office about what's happening in the individual market and general carrier rate increases that have been authorized in the fully insured market by OIC. And then the Health Benefit Exchange has its unveiling of various rates, and people try to line up and compare and go, is everybody kind of in the same pack, or is one part of the market higher or lower than the other, and then everyone tries to learn from each other? I would just caution people from comparing the employee premium percentages and dollars as the correct apples to apples comparison for other parts of the market. Probably the increase in bid rate year over year is the better apples to apples comparison. And I say that because of the impact of the EMC on that negotiated part of the collective bargaining rate. That's not part of the individual market in general or on the Health Benefit Exchange. So what I'm cautioning is don't take 26, 40, 24%, those types of percentages, and then read other news releases that have high single digits or small double digit increases and go, wow, something's going on completely differently in PEB and SEB. The right comparison for us to compare the PEB and SEB parts of the market to the rest is more the bid rate and a year over increase there. So just wanted to caution people because I will get that question, I'm sure, here shortly from other parts of the market or people who are looking at different areas. So wanted to say that. Tom, you have your mic on.
Yes. I think this is more just for people that are listening in, but when we talk about negotiation processes, that might be true for the different Kaiser plans, but for Uniform Medical, that is not a negotiated process. It is what you do when you meet with your actuarials, and that's how you come up with the premiums, correct?
That is correct.
Yeah.
And because it is a self-insured plan, the state is the one who takes the risk for those plan offerings. So HCA ultimately makes some of the final decisions on where those plans come in consultation with our actuaries.
I see Kurt too.
Yeah, thank you. First of all, thank you for the historical employee premium document. Helpful to me. I don't know if I've seen.
We'll
that
just go ahead and go to
before.
slide 9. Yeah, perfect. Because I think that's what you're referencing. Yeah.
Yeah, I thought she'd already gone there, but, sorry, but, okay. But my question was about UMP plus, and maybe this was covered. If it was, I'm sorry, but how much did the, eliminating that plan impact the rates of the other plans within UMP?
That's a good question. I'll bring that back to you. It was minimal, if anything. There wasn't a huge change in Classic as a result of it. We did have to make some assumptions on where those people would land and how some of those network efficiencies kind of impacted it, but I did not have that with me today.
Yeah, I think, little impact is a good enough answer for me.
Okay,
I was
yeah.
just curious, because the intent, I think, of the legislature was cost savings,
Yeah,
right?
correct.
Apparently not cost savings to any subscribers, just the agency and I guess the overall state budget. But I just, layman would think, well, you're closing one plan, that might help lower the cost of the other plans, but that's not the case.
Yeah, they are a smaller population than Classic. They have a different risk score than the Classic population. There has to be some assumptions around where those members will land. UMP for, kind of network standards kind of seems to be, where some of those could go from a rating perspective because they would maintain their same provider if they chose a UMP plan. But I think some of it still will have to come out in the wash after we see where those employees elect to enroll after open enrollment. Because when you look at the premiums from 2025, there was a plus premium of 158, which actually was above and beyond the Classic rate of 134. So those members could choose to enroll in Classic and experience a decrease actually in their premium in 26. There are some difference in the benefit design. The deductible was lower, free primary care cost savings, cost sharing. But I believe that what was rolled through the rate was, if any, I'm thinking it was nothing. And if it was very minimal. So I can bring that back to you, Kurt.
Thank you.
Makayla.
I'm just going to apologize because I know you've covered this
Yeah.
before, but for slides 4 and 5, can you, I get the math and like how it's done. Can you remind me of the why that you choose uniform, like our self-insured model
Yeah.
to be kind of the baseline
Yep.
and not do an 85-15 like individual mathematically for each of the insurance providers?
So before the EMC model, we had what we called a state index rate model, which took an averaging. It did a weighted average off of all the plans. So how many adults units we're going to enroll in each individual plan. And then we did a weighted average for the 85% of the total, the total plan offerings. So when you're averaging in lower price plans like the high deductibles, and at the time there were some other lower price point plans, it was actually bringing down the employer contribution. PEB has always had the EMC model. When we transitioned and had the discussions around moving to the EMC model, it kind of looked at eliminating some of those lower price options, and it was a increase to employees then at that time because the state's picking up a bigger share. And really, when we looked at which plan do you benchmark, I think the reason Classic became the benchmark plan is really UMP Classic is available nationwide, where our other, Kaiser offerings are limited to certain counties. So UMP became kind of the natural benchmark. It was the richest plan and one of the most expensive at the time that this was bargained. So not only was it a win for employees at the time because it was one of the richer, more expensive plans, it was available nationwide, and really was kind of our like what we considered our flagship benchmark plan that the state ran. Some other reasonings are really, we as a state being a self-insured plan for UMP, we have full insight into what's going on in that rate, how that rate is developed, where it's set. We can really see under the hood and really understand all of the components of that rate. So that was kind of the obvious answer. Does that help answer some of your questions?
One other context was before the benchmark was picked in the collective bargaining agreement, there were other parts of the collective bargaining agreement that already referred to UMP Classic and put parameters around ensuring that there wasn't kind of like a cost shifting from the employer to the employee. So there was already that plan that was had some protections around it from the represented employee perspective, and so it also became a natural focal point for the benchmark in an EMC model. And it also is the plan that has consistently had the largest enrollment. So when Tanya says flagship, it's also kind of the predominant enrollment and has that longevity.
Yeah, and I mean, I guess the main reason asking is like, there's the like, why do you do it this way? And there's the because it's the way we've always done it. And then there's a no, this is the criteria, so that if that criteria were to change in the future, you could then prompt to say, well, might we want to look at it?
Yeah.
But what I hear you saying is, I mean, if we're only trending more towards more people involved in UMP and it's beneficial to the employees, then you want to keep that criteria? Is that?
Well, the EMC methodology is up for it's on the table each bargaining cycle because it is defined in the collective bargaining agreement. So I mean, it could change. It's only been in place since 2024. So we switched from the weighted average methodology to the EMC for the 24 plan years. So this is just going into our, third year of it.
But if it were to change, it's a 2-year outlook.
Yeah.
Because the collective bargaining agreement that was just ratified in the legislative process takes us through plan years 27 and 28. Because when Tanya says the change was made to the EMC model for plan year 2024, that was bargained in summer of 22.
Seven.
Yeah. Yeah.
Yeah. The bargaining agreements are the biennial.
This is why I have no idea what year it is,
Yeah.
unless I look at a calendar.
All right. So I think we've kind of jumped around a little bit, but on slide 9, we do have those year-over-year comparisons. This is a newer slide this year. We just thought it would be helpful for some of our board members. I think a lot of our board members have been around, but this really kind of shows what our employees experience year-over-year when they elect to stay in the same plan. You're all aware we don't have an active open enrollment. So if a member chooses to stay in their same plan, this kind of shows some of the premium volatility members can experience or cause members to want to look at other plan offerings. I did include plus on here, even though I said it wouldn't be in the 26 rates, but I wanted you to kind of be able to compare when plus closes and what members are experiencing in 25 in that plan to what they could experience in 26. Harry?
Yeah, thank you. Can you recall, like, I know you can, what is the employer EMC this year?
Yeah, I have
Did you cover that already? I missed it.
No, the EMC this year is actually 759, so it's an 8% increase. So we've had an 8% increase 2 years in a row for the EMC.
What is the number?
2024 was 702, then it went to 759 this year, and then it'll be 850
Okay,
next year.
thank you.
820. And then 820.
So can I ask a question? So this looking at this historical employee premiums, I'm just curious when you see like if you look at Kaiser Northwest Classic, let's take that as an example, and you saw in 22, it was 159, and 23, it was 172, which is a minor jump. Then you see 2024, it jumps to 331. Did you track the kind of response that they had in terms of the how many people were in it then, how many people left and switched to other plans?
Yeah, I believe there was about 20% total of Kaiser members in that year that wound up picking other plans. I think most of us were here for the 2024 rate setting year. We had some very lengthy, in-depth, difficult conversations. In fact, Kaiser attended some of our board meetings, which was unique, but that was a particularly difficult year for 2024. Some things then happened in 2025 to cause our rates to be able to decrease and put some downward pressure on those rates for Kaiser in 2025. And then we are trending up in some plans again for 26, but not in all of them.
And Tom, what takeaway that I'm going to have is we added this 5-year historical premium singles. This is single subscriber, so this is not the family coverage or after any of the tier factors. We always root in single subscriber because we thought that it would be helpful context. And what I'm hearing also is a slide that has enrollment trends over the 5-year might be additionally helpful.
Yeah.
So I've marked that down for inclusion in kind of like our what will become our new standard template with additional context.
We can
to
add
have.
that for next year. Just keep building on it.
Yep.
Thank you.
And then the last slide for the employee premiums. Kurt, I think this one is for you. Shows the tier factors across the 4 tiers. So we have the tier factors listed again at the top, and this shows what each individual employee, depending on their family enrollment, would look like. So what we've been talking through to this slide is just that first column, subscriber only, but then you can see the various tiers all the way up till to the full family, 2.75.
And one more question.
Yeah.
So, no matter whether we're talking about Medicare, non-Medicare, active employees, the factoring is still done exactly the same
No.
way. So subscriber 250, no?
No. Non-Medicare retirees and employees are the same tier factors,
Uh-huh.
but our Medicare retirees follow a completely different set of tier factors.
No, I mean though, in terms of, so if I'll just use this number here, 256 for a subscriber. So you have a Medicare subscriber, I don't know, 140. Is it for the subscriber and spouse 280? So in other words, it's double plus minus $5.
On Medicare, yes.
Yeah.
A Medicare individual plus a Medicare individual. So they're both one. So a Medicare eligible subscriber plus their spouse is ×2.
Yeah,
Where it
minus
-5 because we don't charge twice for the admin. Where it gets a little more complicated, Tom, and we have a lot more tier factors is when there are non-Medicare and Medicare accounts. So where a subscriber is maybe Medicare eligible, but their spouse is non-Medicare eligible. The non-Medicare eligible spouse pays the full rate that we're going to walk through here for non-Medicare. Or if there's a Medicare subscriber that has a non-Medicare child dependent. And then we get into additional multipliers when there's additional Medicare eligible dependents. So like Medicare eligible for disability. If a Medicare retiree has a Medicare eligible dependent, that's maybe by reason of disability. If they have 1 or 2, the tier factors do get a little more complicated for split accounts or the Medicare tiers.
The way I think of it, Tom, is in this area, we use a lot of multiplication ×2 ×1.75. When we get to involving a mixture of Medicare and non-Medicare accounts, we figure out what each person in, and it's additive. There's not really multiplication there, with some subtraction of the admin piece in general. I'm overgeneralizing, but
Yes.
in general, I think of it as like you have to figure out this person, this person, this person, add those together, make sure the admin isn't double, tripled, et cetera. Whereas in the employee place and the matching non-Medicare account, it's easier, just straight multiplication.
And we can't present that for this situation because there's a lot more iterations of who could enroll where that we have to like match together. So. Yep. More questions on employees. We're going to move to non-Medicare, but you can interrupt me throughout if something comes up. So non-Medicare retirees, as a reminder, these are our retirees who are not yet eligible for Medicare. So they are in the non-Medicare risk pool, which is comprised of all of us state active employees and those retirees who are not yet Medicare eligible. These retirees do not get an explicit subsidy like our Medicare retirees, but what they do get is what we call an implicit subsidy. So because they are in the risk pool with us state employees, they pay the same full bid rate that our carriers bid for our active population. So they're implicitly subsidized by being rated with a younger population. So these non-Medicare retirees pay the full bid rate plus that admin fee that Tom is referencing. So on this next slide, we have the proposed 2026 non-Medicare retiree premiums. This layout is very much the same with the carriers, the plan offerings, and then comparing their 2025 versus their proposed 2026 rate. So they pay the entire bid rate, and you'll see the dollar increase as well as the percentage increase here for these retirees. The next slide just shows these non-Medicare retirees by tier because, Tom, like you mentioned, the non-Medicare retirees follow the same tier factors as the active employees. Questions about non-Medicare retirees? All right. Okay. On the next slide, we're going to move on and talk a bit about some additional proposals that were submitted by our carriers. So there were some additional proposals that were made that are not being brought forward for board adoption or not being included in the rates that are proposed to you today. This is just a really high-level illustrative example of the types of proposals that can be made by carriers to put downward pressure on premiums by increasing out-of-pocket costs. This is just an example, but in this example, it looks at reducing the monthly premium by $20, which is $240 when you multiply by 12. So annually, this would put downward pressure on monthly premiums by $20. And in turn, increase the annual deductible from $200 to $500. So this is a $300 annual increase. Just to note, this is illustrative. We don't even have a plan with a $200 deductible. We acknowledge not everybody is going to meet their deductible, so there would be some, maybe winners or losers in this example. But these are the types of proposals that we have received this year that are not being included in the proposed rates today. So on the next slide, some of the reasoning behind that is we believe changing the benefit design while maintaining our existing plans could result in confusion for our members. We do not have an active open enrollment, and a lot of members are very sticky with their plans. They look at the price point of that plan and decide to stay with it or not. And by doing this kind of cost shifting, members could get some unexpected out of costs. In the scenario we had, if that member was somebody who would meet their deductible, they would experience actually an increase in costs. And then I guess I covered my second bullet. Dave, anything else on this one?
No, I just think it might be appreciated if there are insights from the board about this relationship between premium and cost shares and where prioritization is and thoughts around that. This would be an excellent time for any board member insights or questions on this particular point. Michaela.
Well, one of the questions I was going to ask was the proposal to apply it to across the board? Because when I think of like a CDHP versus like a classic, as an employee, it gives me the choice to say, which one do I want to go for? When I was single without kids, I was going for the high deductible because I was kind of rolling the dice.
Yeah.
Whereas now with multiple kids, I'm looking for, I don't want to spend that huge out of pocket. So I think it's like, as long as you have a choice. And so when I see this as an option, I would be concerned if it were to apply to everything, because that's then kind of moving toward everyone towards more of that CDHP model versus giving people who again, like I have one kid that has been in and out of the ER and it's like, no, I just want to pay I want a low deductible and I just want to like cover it all right then and there. So, or I mean, yeah, I want to pay it so that I don't have to have a high deductible.
No, there was not one set proposal. The example I gave was just a made up example. But there was not an across the board, everybody's deductible increases or everybody's out of pocket increases. And there were trying not to cross any proprietary nature, but no, there was not an across the board proposal made.
And we're just balancing the conversations that happen in executive session. So I just want to assure people that board members saw very specific proposals. And then the agency is bringing forward the single set and explaining kind of the cost share philosophy. That's why I thought it would be important for the board to know that. And so just making sure that it's clear that board members saw full things and that, and you're also trying to help the public understand some of the nature of the conversation too.
Yeah, so I guess what I just emphasize is like continuing to give people choices so that it's not moving everyone towards one model.
Yeah. Harry?
Yeah, I think for this year, this all makes sense, but I'm kind of sensing that what I'm hearing is this in a too hard to do box and an unwillingness to consider alternative proposals. And the way we've done it in the past is by rolling out a new plan. We rolled out the UMP Plus, and we rolled out the Select. But, the fact is, I don't think many of the cost sharing within the UMP plan has changed in the last, 8, 10 years maybe. And so I do believe that over time, that relationship changes. You can't to me, expect to have a $20 copayment, if that's what it was, just take that number, for 10 years and say, well, in reflection, it has really, the cost of business has increased and you don't raise it each year from $20 to $21.32 incrementally. You wait till you have to, and then it goes to $30 and it becomes a big deal because it's a 50% increase. So I guess what I'm saying is I don't want us to reject the notion that an alternative proposal is reasonable. But it has to be done a couple of years out, probably, because this big boat is too hard to turn. And you got the collective bargaining and all that, and you got to keep it in that sync of 85-15 or whatever. So I guess that's a lot of words to just say that I'm open. I think the board ought to be open to some alternative proposals, provided they could be not a reaction, but an anticipation. Thank you.
All right. Elia?
Well, one of the things that I run into representing retired state employees is they want to know why the rates go up. And it can't be, I can't tell them, well, we anticipate. Well, they'll say, well, so it hasn't happened? Why are you charging me? Why are you doing this? So there are two ways of seeing it. It's one thing to tell a retired employee, this is why this has happened, cause and effect. But they'll say, well, how do you know that's going to happen? Or we'd have to have a lot of data and a lot of, you get a lot of questions. And so I guess it depends how it would be done. If you could say, we're looking at this, we're looking at this, we're looking at this, and it's only a matter of time, you'd have to have a lot of data to back it up.
And at that point, Elliot, I think you're highly on the relationship and communicating with the consumer about change in premium and its relationship to a change in benefit design exponentially makes that conversation harder. And there's a time and a place and a strategy behind it. To Harry's point, $20 10 years ago isn't the same as $20 today. And I think, there was one of the last times I know that there was a big cost share change in UMP was increasing, I think, the emergency room copay because that helped steer people towards urgent care. And that steerage aspect for care delivery might be a strategic reason for adjusting cost shares. But this piece, going back to the communication aspect of it, when the consumer, especially in our portfolio, has often longevity with a particular plan name, for example, and they experience that and they're watching premium and they see premium go up. This was kind of a conversation that happened yesterday at the subboard meeting in public. It's like, there's this natural understanding that, for better or worse, we all realize that like our healthcare costs we're in a place where they're going up and it's actually unusual for it to not go up. And it actually prompts more questions if it doesn't go up even a little. And that prompts even more questions if it goes down because it's like, wait, did I just lose coverage for something? Like, healthcare doesn't go down. That's not in the everyday experience of the consumer. And so it prompts more questions. And so there's this piece of this relationship and being able to communicate it and help ensure stability that there's not this this change in what is actually covered simply because premiums stayed the same, that the average consumer may struggle with that concept at first. And so thinking about the more strategic times and ways in which to either introduce a new plan that achieves similar objectives, but there's this kind of new product on the shelf that you're comparing to instead of understanding what your current experience is that's changing or would change. So appreciate you bringing up kind of the communication challenge of all this. Go ahead, Tanya.
Yeah. We're going to move on to some of the other benefits that are offered alongside medical. So the first one is vision and dental premiums. For our employees, vision and dental is 100% employer paid. So the employees do not have to pay these premiums. For our non-Medicare retirees, these are the vision rates. And then for our non-Medicare and our Medicare retirees, these are the dental premiums. So if we start out at vision, these are going to be in a rate guarantee through the end of 2027. On our dental and vision plans, we like to try and negotiate rate guarantees for a multi-year period with our carriers. So this reflects that multi-year rate guarantee for vision.
Tanya, can you go? So 2025 was the last year of the prior rate guarantee?
I believe so. So these will go through 27 now.
Or to 28?
Through.
Because it's, oh, sorry, I'd moved on to dental. I thought you'd moved on to dental.
No. So I think they were 25, 26, and 27. Yeah. So for dental, these were new rates that were negotiated. And similar to medical, I'll just point out that we have another dynamic of, negotiating with the carriers versus developing our rates. So for medical, the uniform dental plan is synonymous basically to uniform medical plan. Where we are creating that rate, we're not negotiating with Delta Dental. We are establishing that rate. Versus the Delta Care and Willamette rate, we actually negotiate and we're more takers of those rates and take their best and final rates. These rates were negotiated, which will get us through the end of December of 2028. There was kind of a mixture of prior rate guarantees that we're moving off of here on our fully insured dental products. So when the carriers have a prior rate guarantee for a longer period, and then we're coming off of that, we can see some larger increases because they're catching up with some of those maybe where things were underpriced or they have increased reimbursement to specific provider types. So you will see an increase in our Delta Care and our Willamette plan. The uniform dental plan also includes the increase that was included in the last budget, which is the enhanced TMJ benefit and the removal of the deductible for children under the age of 15. So that is rolled into the UDP rate as well. I will acknowledge the cost of that was very minimal. Tom.
So looking at the historical timeline, and I remember I joined the board in 2019. And I did a chart because I was really curious about uniform dental and actually how little it changed.
Yeah.
I think I went all the way back to 2010 and compared it across the timeline. But each year, there was a new, for these three, there was a new rate. And so this is the one change is that, if I'm understanding this correctly, is that, for example, Delta Care 4648, that would be guaranteed for 2026, 2027, and
Yes.
2028.
Correct.
So you will not have to go through that every year cycle. And then for vision, that would be is this the rate that we currently have for this year?
Yes.
And then 26 and then
Yes,
27. Okay.
correct. I will note one nuance to dental. So when we talk about a rate guarantee for the uniform dental plan, we do negotiate with Delta for their admin component to be in a rate guarantee. But because we're developing the UDP rate ourselves, we look at the actual cost and utilization of that plan each year and will bring forward a new rate for UDP every year. We don't do a rate guarantee with ourselves. And that's what leads to some of the volatility a little bit with the rate guarantee with the fully insured dental. You know, they're blending multiple years into that rate where we are doing 1 year at a time. Okay, on the next slide, we're going to move on to life and accidental death and dismemberment. Basic life and AD&D is employer funded with no premium change, and then supplemental life and AD&D, which is employee funded, also has no change. Just a reminder, as employees move through the different age bands, they can experience an increase, but the rates are guaranteed through the end of 2029. And then we've talked a bit about LTD, so I won't stop too long on these because Kimberly was here for the last couple meetings presenting on LTD. But this is just to kind of include it all in one premium rate slide. The board took action last month, and the employer paid LTD will be increasing from $240 to $450. And this comes along with a decrease of employee paid LTD premiums by about 6%. And those are included on the next slide, also presented by Kimberly last month.
And a real quick reminder, so the board has the authority for setting employee premiums, but not for the employer paid benefits. And so when it comes to LTD, sometimes this is complicated. Sometimes we have you vote on the benefit design, and then that inherently produces a rate. And in other times we have you vote on the rate, and that is the embodiment of the benefit design. So a couple of meetings ago, the board authorized the increase on the LTD employer benefit, and that inherently embodied the shift that will happen in the employee rate. So there's not a separate resolution on the employee paid LTD benefit because it was subsumed and part of the collateral effects of your vote on the LTD employer paid benefit. So I just wanted to explain, it was like, you were like, oh, do we have to vote on these employee rates? That was a collateral effect. I don't know if everyone remembers me pointing that out at the time, but I like to try to pick it up on both parts of the journey whenever we're talking about things. So you've already done your work on LTD on the rates that impact employees inherently. That's why you're not seeing another resolution there. And that's why we don't bring you a vision resolution and a dental resolution, because the authority of the board isn't over or inclusive of the employer paid benefits.
So next up are the proposed resolutions that I'll be bringing you next week for authorization. I'm not going to read through all of these, so we'll just do a little stop here on the Kaiser Northwest example. They're all structured the same way. There will be one resolution per carrier, and by the board authorizing that carrier premium resolution, they would be authorizing the plans that were presented, as well as the underlying benefit design changes. So Beth presented on a couple minor changes. Those are included in the rates. And by the board taking action on this resolution, it authorizes the premiums for all of the plans by that carrier, as well as the underlying plan design. So there will be a separate resolution for Kaiser Northwest, Kaiser Washington, and the Uniform Medical Plan. And that is all I have for you.
Any other questions for Tanya? Tanya, thank you so much.
You're welcome.
Appreciate it. Lots of information. Dave's going to give us the 2026 board schedule. They're behind tab number 7.
It is, it's not afternoon. It's still good morning, everyone. So At this point in the board meetings, board season, we bring forward to you the proposed meeting schedule for the next board year. I'll bring it back as kind of a final in case there's any feedback here. After the next board meeting, we'll have it filed with the code revisor, and then they are officially meetings. There is no huge variance in the proposed PEB board design of the board season for next year. January would have a longer, mostly all-day retreat. Then we proceed into March, April, and May singular meetings, roughly the second Thursday of the month. All of the meetings dates that are proposed here are Thursdays at 9 a.m. We try to be very consistent on when this board meets. We have a little bit more variance on the sub board, but I've always wanted to know, knowing that there are more retirees that engage in the public part of the meeting, I've tried to make it as simple, it's always Thursday at 9, have that kind of schedule. So that is maintained here. We always also take into account, we're looking at the legislative calendar, we're looking at state holidays. We do factor in a variety of different pieces to try to keep the schedule as consistent as possible. When we get into June, we've classically had 2 board meetings. A lot of May and June is about having executive sessions to keep you apprised of where things are in the rate negotiation process. And then when we get into July, we overschedule instead of underschedule because it's easier to cancel meetings that are already scheduled from an open public meetings perspective than to schedule them. We usually only need 2 of those July meetings. Sometimes, some years though, we've needed 3, and in a rare instance, we've needed all 4. So again, it's important to keep them all on the books. We are, especially in July, we think that we will be able to maintain for sure half-day meetings. It's going to be even more incumbent on us because we are proposing for the sub-board that they meet in the afternoons of the same day. So we'll do morning meetings with PEB and afternoon meetings in SEB. So we really do think that those July meetings, when they're held, will be done before kind of the lunchtime. The other meetings, it will just depend on the variety of information and whether it spills into the early afternoon or not. So that's really the proposed schedule. If you were to line up year over year, they're pretty consistent along the way.
Any questions for Dave?
Dave,
Sure.
do we anticipate meeting on the 24th this month?
At this point, we're anticipating that next board meeting could be the last board meeting. We aren't going to officially cancel anything until after the board has taken action on the non-Medicare portfolio. But once that's done, then we would not have the meetings on the 24th or the 31st. I think John, you're asking the question John always asks. Last meeting, I said, I think we could take the 31st off the books. We're just going to wait, and we didn't even officially take the 31st off the books yet.
It's very hard to put it back on the book.
Yeah, but it seems likely that next board meeting will be the last board meeting, but we'll know next week.
Other questions or comments? All right, I think we're at public comment. So we're going to go ahead and capture a list of individuals. If you are out in the public, if you're in the room, raise your real hand if you'd like to make comment. If you're in Zoom land, please raise your Zoom hand and we'll keep track of you. Now, remember, if you're in Zoom land, we're going to be, when we highlight you, you'll have the ability to activate your audio and video for comment. So seeing none in the room. Seeing going once for the public. Going twice. No public comment today. All right. Our next meeting scheduled for July 17th, starting at 9. It's going to have the same format and attendance in person or via Zoom. Dave, any final comments before we adjourn?
Preview of coming attractions for the next board meeting. We'll bring back the hearing aid resolutions for action by the board. We'll bring back the resolutions on non-Medicare and employee premiums that Tanya presented a few moments ago. The last board meeting of the season, we always, or the last anticipated one, we always do an open enrollment pivot to the readiness and the work that the agency is underway, but it kind of officially marks the final turning point. Alyssa will say she's been working on open enrollment since March, which is true, but there's definitely this pivot that happens after the board has taken action. Because if you can believe it or not, I might get this off by a day or two, but we're 77 business days from open enrollment. Last time I said like 120, I was doing calendar days, but everyone reminded we should do business days. It's a lot closer than people realize. So we'll have an open enrollment readiness presentation to talk about that pivot. And then in response to board questions from earlier in the season, we'll have a presentation about what it looks like for the steps that are necessary if the board wants to expand the offerings within the portfolio. So we'll have a presentation about that overall procurement process. And then we will have the bring back the board meeting schedule for final thoughts before we file it. And that will be the end. Don't anticipate an executive session next meeting either.
Any final comments from the board? Dave, thank you to you and your staff. Lots of great work. I know a whole bunch goes into this. I really do appreciate it. Thank you for the board for all your energy, time, and effort on this. This meeting is adjourned. Thank you.